Hey everyone, welcome back to ShockDoc Medical. This is Dr. Raad coming at you with another deep dive into the world of medical innovation. Let me ask you something. Have you ever wondered how a small skin lesion could cost our society billions of dollars and rob us of millions of workdays each year? Today we're exploring leg ulcers, a condition that might seem minor at first glance, but is in fact a huge public health challenge. Leg ulcers affect about 1 to 3% of the population, which translates to roughly 9 million people in the United States alone. And get this, the annual cost of managing these ulcers is estimated at a staggering $8 to $10 billion, with up to 2 million workdays lost every year. Most of these ulcers hit middle-aged to elderly patients, and there's a noticeable trend. Women get hit about twice as often as men. Today, we're going to unpack everything you need to know about leg ulcers, from the underlying causes to the nitty-gritty of treatment options. Whether you're a healthcare professional or just a curious mind, this episode is a must-listen. Now, leg ulcers come in 3 main flavors: venous, arterial, and neuropathic. Each type has its own set of causes, clinical signs, and management strategies. So, grab your coffee, sit back, and let's break it down. First up, we've got venous ulcers. These bad boys account for 70% to 80% of all leg ulcerations and are often referred to as stasis ulcers. They're primarily the result of chronic venous insufficiency, which means the veins aren't doing their job properly, often due to varicose veins, post-phlebitic syndrome, a history of deep vein thrombosis, obesity, or even previous leg injury or surgery. Imagine your calf muscles working like a pump when you walk. They help push the blood up and out of your legs. But if the valves in your veins are incompetent, blood pools, leading to venous hypertension. This elevated pressure causes tissue hypoxia. Basically, the tissues don't get enough oxygen, which eventually leads to skin breakdown and ulcer formation. And once the skin's integrity is compromised, the normal wound healing process gets thrown off balance. Clinical presentation. Patients with venous ulcers often complain of a heavy or swollen feeling in the affected leg. The pain can vary from mild discomfort in superficial ulcers to severe pain in deeper ones, and sometimes movement becomes limited. Plus, many patients with venous stasis and dermatitis experience significant itching around the ulcer area. On physical exam, you'll usually find non-pitting or pitting edema, visible varicosities, and hyperpigmentation from hemosiderin deposition over the shin. Venous ulcers are typically seen over or proximal to the medial malleolus, though they can appear anywhere below the knee. They can be single or multiple, small or large, shallow or deep, with well-defined sloped borders, or even irregular shapes. Often you'll notice fibrinoid material or granulation tissue at the base, and sometimes there's copious drainage. Laboratory and diagnostic clues. While there isn't a specific lab test that screams venous ulcer out loud, a complete blood count, CBC, and erythrocyte sedimentation rate, ESR, and blood glucose levels can help uncover underlying conditions like inflammation or diabetes. A culture might grow mixed flora, nothing unusual unless there's a clinical infection. And don't forget the venous Doppler ultrasound. It's a handy tool to locate venous occlusions or incompetent perforating veins. The key diagnostic features: well-circumscribed ulcers on a background of hyperpigmentation, varicosities, and edema, with palpable pedal pulses and sometimes fibrinoid material at the base. Management of venous ulcers. Now, when it comes to treatment, the primary goal is to reverse venous hypertension and create an environment that's friendly for wound healing. And the gold standard here is compression therapy. There are 2 types: inelastic compression products, think Unna boots or Profor boots. These are occlusive wraps applied much like an ACE wrap in the office. They're typically removed after 1 week and can even be applied at home by a trained professional. Remember, always rule out arterial insufficiency before applying compression. Elastic compression products. Once the ulcer is healed, products like TEDs or Jobst stockings are used for maintenance to prevent recurrence. Along with compression, you need to prepare the wound bed. Debridement, the process of removing non-viable tissue, might be necessary. This can be done surgically with scissors, a curette, or a scalpel, often with local anesthesia, or chemically with enzymatic agents such as Santyl, Panafil, or Accuzyme. Moisture balance is crucial. For wounds with heavy exudate, dressings like Kerlix, gauze sponges, surgical pads, hydrophilic foam dressings like Copa, or hydrocellular polyurethane dressings such as Alevin are great choices. If the wound is dry, consider dressings like Telfa, Vaseline petroleum gauze, or non-adhering oil emulsion dressings like Curity. For promoting reepithelialization, you can use hydrocolloid dressings like Duoderm or Restore, or extracellular matrix dressings such as Oasis or Matristem. In some cases, biologic agents like Apligraf or Dermagraft provide the building blocks for new skin to form. And if there's any sign of infection, say a thick, odorous exudate or surrounding erythema, culture the wound and then treat with an oral antibiotic. Oh, and for stasis dermatitis adjacent to the ulcer, a mid-potency topical steroid like triamcinolone ointment 0.1% can help maintain the skin's integrity and lower the risk of cellulitis. Keep in mind, treatment can stretch on for months, and recurrence is a major issue. Studies show recurrence rates between 54% and 78%. If you're stumped by the underlying cause, or if the ulcer isn't healing despite proper care, it might be time to consult a specialist like a vascular surgeon or dermatologist, or even refer to a dedicated wound care clinic. Let's switch gears now and talk about arterial ulcers, which account for about 6 to 10% of leg ulcers. These ulcers typically develop in the setting of peripheral arterial disease and are often termed ischemic ulcers. Sometimes you even see a mixed picture where both venous and arterial factors are at play. Pathophysiology. The major risk factors here include peripheral arterial disease, cigarette smoking, diabetes, hyperlipidemia, and hypertension. Unlike venous ulcers, arterial ulcers tend to occur more in men. The underlying issue is reduced or completely obstructed arterial blood flow, often due to atherosclerotic plaques narrowing the vessels, which leads to tissue ischemia and necrosis, and eventually the ulcer forms. Clinical presentation. Patients with arterial ulcers usually complain of intermittent claudication. That's the pain in the calf during exercise in the early stages, which eventually turns into pain at rest as the disease worsens. They often find relief when they let their leg hang down, which improves blood flow. These ulcers are typically very painful, more so than venous ulcers, and are usually found in distal locations, often over bony prominences like the toes. They have a distinct round, punched-out appearance with sharp edges. The base of these ulcers is often dry and can be covered with necrotic debris, forming an eschar. One of the key exam findings is the absence of pedal pulses, and the surrounding skin tends to be shiny, atrophic, and hairless. Laboratory and diagnostic tools. A crucial test here is the ankle brachial index, ABI. This is the ratio of the ankle systolic pressure to the higher of the brachial systolic pressures, and an ABI of less than 0.8 indicates occlusive arterial disease. Duplex ultrasound is another valuable tool to identify arterial occlusions or atherosclerotic changes. As with venous ulcers, a CBC, ESR, and blood glucose level can help unearth underlying conditions, and if you suspect infection, a culture is warranted. Management. When dealing with arterial ulcers, compression therapy is off the table. It can actually worsen tissue ischemia and lead to necrosis. Instead, the focus is on reestablishing adequate arterial blood flow. This often means referring patients early to vascular surgery. Lifestyle changes are paramount. Patients should quit smoking, adopt a low-fat diet, and work on better control of blood pressure and blood sugar. To help prevent ischemic events, antiplatelet medications like aspirin and clopidogrel can be very useful. Typically, we use aspirin at 81 milligrams daily and clopidogrel, Plavix, at 75 milligrams daily. Pain control is also a major consideration, so systemic medications alongside effective local wound care are key. And if there are signs of infection, such as exudate or surrounding erythema, be sure to obtain cultures and consider systemic antibiotics. Almost every patient with an arterial ulcer should be evaluated in conjunction with a vascular surgeon because surgical intervention might be a necessary component of their treatment plan. Now, let's talk about neuropathic ulcers. These are particularly common in diabetic patients. In fact, up to 10% of all leg ulcers are neuropathic. And in the United States, around 20% of people with diabetes, roughly 3 million individuals, will develop a foot ulcer at some point in their lives. And here's the kicker. Up to 25% of those patients may eventually require an amputation. Pathophysiology. The vast majority of diabetic patients develop peripheral neuropathy. This lack of sensation means that repeated trauma and pressure on the feet, especially at pressure points, go unnoticed, eventually leading to ulcer formation. Additionally, neuropathy can lead to foot deformities, which further predispose patients to injury. Autonomic dysfunction also plays a role by causing hypohidrosis, which makes the skin dry, fissured, and calloused. And while diabetes is the most common cause, other factors like spinal cord disease, alcohol abuse, and leprosy can also contribute. Clinical presentation. Neuropathic ulcers are usually painless, which is a double-edged sword because the lack of pain means patients may not notice them until they become quite severe. Patients might report burning, numbness, or other odd sensations in their feet and lower legs. These ulcers typically develop over pressure points on the plantar surface of the foot. Think the great toe, metatarsal heads, or the heel. They're often surrounded by a thick callus that can mask the full extent of the damage, and in severe cases, you might even see bone or tendon exposed. Foot deformities like claw toes, flat feet, or Charcot joints are also common. Laboratory and diagnostic workup. Just like with the other types, a CBC, ESR, and blood glucose level are useful. If you suspect infection, particularly osteomyelitis, imaging such as an X-ray or MRI is critical, and tissue or bone cultures should be obtained before starting antibiotic therapy. Management. Preventing and detecting neuropathic ulcers early is crucial. Once an ulcer develops, maintaining a moist wound environment is key to facilitating healing. After proper wound preparation, engineered products like Oasis or Dermagraft can promote reepithelialization. Identifying and managing infections early is essential. If osteomyelitis is suspected or confirmed, prompt parenteral antibiotic therapy should be initiated. Debridement is also a cornerstone of treatment and can be achieved through surgical means using a scalpel, mechanically with wet-to-dry dressings, or enzymatically with agents like collagenase. Another critical component is offloading pressure from the affected area. This might involve the use of orthotic devices with cushioning, and consulting a podiatrist can help tailor the best approach for each patient. When to consult? For neuropathic ulcers, it's often beneficial to co-manage with a podiatrist who specializes in orthotics and foot procedures. And if there's an arterial component present, a vascular surgeon should also be brought into the discussion. So, to recap, leg ulcers are a complex and costly problem affecting millions. We've broken down the three major types: venous ulcers, mostly due to chronic venous insufficiency, treated with compression therapy using UNA or Pro4 boots, and then TEDs or job stockings, debridement, moisture balancing dressings, and sometimes topical steroids like triamcinolone ointment 0.1% if stasis dermatitis is present. Arterial ulcers, typically linked to peripheral arterial disease, requiring strategies to restore arterial blood flow, lifestyle modifications, antiplatelet therapy, aspirin 81 milligrams daily and clopidogrel 75 milligrams daily, and early referral to vascular surgery. Neuropathic ulcers, most commonly seen in diabetics due to peripheral neuropathy, managed by keeping the wound moist, using engineered products like Oasis or Dermagraft, aggressive debridement, and offloading pressure with orthotic devices, always in close consultation with a podiatrist. Each type has its own set of diagnostic clues, laboratory assessments, and management protocols, making it essential for healthcare providers to understand these nuances to offer the best care possible. All right, folks, that's a wrap on today's comprehensive look at leg ulcers. I hope you found this deep dive as enlightening as I did. Whether you're a healthcare professional looking for practical insights or someone curious about the latest in medical research, understanding these details can really make a difference in patient care. If you enjoyed this episode, please hit that like button, subscribe to ShockDoc Medical, and share your thoughts or questions in the comments below. Let's keep this conversation going. After all, the more we share knowledge, the better equipped we all are to tackle these challenges head-on. And stay tuned for our next episode, where we'll uncover another groundbreaking discovery that could reshape the future of medicine. This is Dr. Raad on ShockDoc Medical. Thanks for listening, and until next time, keep questioning, keep learning, and stay healthy.